So happy to be here. These are my disclosures. Now, what's the rationale for retrograde lesion approach in general? To start with, interventional therapy of critical limb ischemia requires that we cross lesions, and often lesions that cannot be crossed from above can easily be traversed from below, and there are many reasons for this. One, a vessel always clots back to a collateral, and so often our wire diverts out a collateral. Often the operator cannot discern where the true lumen is, and there may be hibernating vessel. Often there's a better geometric configuration or a softer distal cap of a plaque. All of these reasons, we have developed things like pedal approach and we come retrograde. But why transcollateral? Well, the same basic reasons. There are always patent collateral vessels. Whoops, that should not have gone forward. Can you go back, please? There are always patent collateral vessels in a limb with chronic critical limb ischemia. If not, the limb would be dead. We know that coming from below often allows us to succeed, and this approach allows us to access very small vessels that may not be easily accessed via transpedal, and sometimes transpedal vessels may be so hard that we may actually bend needles sticking them. Well, this allows us to get around that problem. And it allows us to access vessels that have overlying surgical wounds or active infection. And it can facilitate opening more than one vessel at a time with a single puncture site. Now, there are obstacles to the transcollateral approach. There may be poorly visualized collaterals. Just as in that coronary case you saw yesterday, you may have to surf the collaterals. There may be small tortuous collateral vessels. Many people have lack of patience. This is not for the impatient. You must be willing to get through the lesions. You must have requisite wire skills, and you must have appropriate equipment. So this was a case I did live 8 years ago for the American College of Cardiology. And what I'm going to show you is what we did. And 100% of what I'm going to show you, we did live in that case. And then I'll tell you what we did after the 20 minutes allocated to that case. This was a 49-year-old diabetic female. She had not taken good care of herself. She did smoke. She had rest pain and an ischemic ulcer on her hallux. But she also had active infection of the great toe with skin rash involving the entire lower leg, despite 2 weeks of antibiotic therapy. She had 2 failed prior femoral to tibial bypasses, and she had dense scar over her distal vessels. So we elected, after we took an angiogram, we see a posterior tibial that's occluded distally. They were unable to cross this elsewhere, and there's this AT, and she'd had bypasses to both of these vessels. So what we did live, some good operators had tried and had been unsuccessful crossing these, so now we're coming into this collateral. This is a nice, generous collateral. We're going to follow with a support catheter, and my wire here, I've kind of sprung the tip, but you will see it's going to suddenly spring up. Now we're going up the anterior tibial. Now we simply track this vessel up. I'm sure this is an area of hibernating vessel. Again, great operators had tried this and been unable to cross from above. We didn't want to stick into this infected site where there was dense scar from prior surgeries. We advance this up. Now we're getting up to where we see the vessel was occluded. This crossed very easily. Again, this was done, everything you see here was done within the 20 minutes that we were on stage. We then steered the wire back into the sheath. We externalized this wire. We reversed it. We came down, we lased, and we ballooned. Now we have established flow into the anterior tibial, but we have one little area of dissection. We have this one distal lesion. So we placed one stent in that area of dissection. We dilated this area, and you're going to see it's wide open. Now I'd run out of time during the conference, but what I then did was come through the foot, open up the posterior tibial, come across, and we opened up the perineal. And towards your point, did we need to open up all 3 vessels? I don't know. But if somebody offers me 1 potato chip, I would prefer 2. And if they offer me 2, I'd prefer 3. You've heard that thing, you can't stop with just 1. I don't know of any penalty if you're not giving a lot of dye to having more than 1 vessel open. And frankly, since restenosis of these vessels is pretty high, I think the more of them we can open, potentially, the better. Now, we can use this all over. I've used this technique to cross SFA lesions, to cross lesions of brachial arteries in a lot of different areas. This can be used with patient and requisite wire skills. Transcollateral access is a useful method for crossing total occlusions, and it allows you to do so with a single access site. It can be used when there's distal infection or extensive cut downs. And in this case, I couldn't show you the leg before as we were doing this live. I probably should have. But there were dense scars with sort of these indentions in the leg, and certainly you wouldn't have wanted to stick through that scar tissue. But if you're going to do this, I have some tips. I strongly advise antegrade approach, and I couldn't agree more with Dr. Zakir in his previous note. When we're working below the knee and you can do it, use an antegrade stick, it's better. I would suggest you use a flexible hydrophilic wire to cross the collaterals, and we have far better wires now than we had when I did this case. I would follow this with a support catheter or center marker balloons to allow you to negotiate and give further support to your balloon. Once all of this is done and you've captured your wire, I think you should exchange for an extra support stiff or sometimes even CTO wires with support if you need them. And I would always advise liberal use of nitroglycerin and other drugs to avoid spasm. When I've seen people have problems with this technique, it was related more to spasm than anything else. And finally, you must carefully pay attention to anticoagulation. Routine ACTs are mandatory. Thank you much for your attention.